queued up for questions, and our leadoff hitter is Bud Foster and then Craig Smith. So, Bud, go ahead.
Bud, you're on mute.
Yeah, there we go. So we're not going to do a summation first. We're just going to go right to questions.
Do you know what? I would like to do a summation just for about 5 minutes, 3 minutes, 2 minutes, if that's okay with everybody. I can do that pretty quick.
Yeah, that'd be great.
Okay, so let me, hi, it's Terry. Let me, first off, thank you for coming. Let me just share with you where we are in the community, in the county, and what I'm going to do is just recite a lot of numbers. I'll try to go a little slower than I did last time, but to give you a sense of what's going on. Today, we reported 401 cases. This is a very high number for us overall. Our number is approximately 168 cases per 100,000. This is significantly increased compared to where we were 3 to 4 weeks ago. You will recall anything over 100 cases per 100,000 puts us into the red zone. Our positivity, that's the number of people that are tested who result with a positive test result, is somewhere between 7.9 and 11%. It seems to depend on the day. We're seeing pretty rapid fluctuation. We know that our number of people that are testing has significantly increased. We are testing now approximately 1,500 to 3,000 people a day. That includes tests that are done at sites that are supported by the state, like the Paradigm and ASU site, as well as Walgreens, CVS, other pharmacy sites, and individual hospitals. As far as our ICU bed and hospitalization beds, as of yesterday, remember, this is a number that is static that I get. It changes throughout the day. We had 11 ICU beds available in the county. We have at times this week had 5 or 6 beds. This is better than last time. In the winter, at times we had no beds available, which is what you're seeing in places like Alabama right now. We had 56 med-surg beds available yesterday. 15% of our ICU was populated by patients that had COVID. That's the highest ICU population with COVID patients since March 2nd. We also had almost 200 inpatients in hospitals in the county that had a diagnosis of COVID. Now, that does not mean there aren't more, but it means at the time that number was reported, people had been diagnosed with COVID. As far as the schools, I just want to spend a little time. You know, we're seeing increasing number of cases. This number changes every hour, but as of approximately 12 hours ago, we had upwards of 800 cases. Approximately a little over 100 were staff, or that means staff and or faculty, and the rest were students. We have declared 30 outbreaks. You will recall that a declaration of an outbreak is done by the county. We do that in conjunction with the school district. At most cases, that is done with the principal and or the lead of the classroom and or the school on a Teams meeting with us, and it may or may not include the superintendent or the lead for that district. And that is my really brief summation, and we can go from there then, Bud.
Okay, thank you very much. A lot to cover here today, but I'd like to ask you about breakthrough cases, if I might. In May, the state reported that 5% of the cases were breakthrough, 8% in June, 11% in July, and now we're at 14%, at least according to the state numbers. How do we get to that when the vaccines have at least 90% efficacy? How do we get to 14%, and what does 14% mean?
So I actually have to admit I haven't seen that data from the state, but I think the question that's being asked is, if you are fully vaccinated, why would there be this significant, what appears to be a significant number of breakthrough cases? As you will recall, with every vaccine, there is sensitivity and specificity. what good coverage it gives, and for a percentage of people where there is not an immune response. So the breakthrough cases reflect that. They reflect people that have been fully immunized. To be a breakthrough case, you have to be fully immunized in 14 days after your immunization. What does this mean? Obviously, I think from a clinical perspective, we remain concerned about the possibility that we are seeing decreasing immunogenicity with the vaccine the further out we get from the last dose. You are seeing that with the recommendations from the CDC and FDA that there be a third dose for those who are immunocompromised. And you are seeing that with the recent recommendation that starting September 20th, people get a third dose. What's important to note, however, is in these breakthrough cases, there is still significantly decreased morbidity. So people that are considered a breakthrough case are not getting hospitalized at any near the rate of people that have been fully immunized. So to sum it up, it's not surprising we're seeing breakthrough cases. One reason for the increased number is we have increased number of people that are fully immunized. So just because of that, from a numbers game, we would see an increased number of people with breakthrough cases. But I think it does reflect this decreased immunogenicity related to time. Thanks.
Okay, next with questions, Craig Smith, and then Nicole will be after that.
Hi, Doctor. Thanks for talking with us. Do you have a picture of how the third shot rollout is going to go at this point? And also, when you track these breakthrough cases, have you been able to look at cases and go, okay, that person's immunization was 7 months ago, that one was 6 months ago, that one was 5 months ago?
So let me take your second question first because it follows on, and it's a great question, and I don't have that information. We're actually in the process of looking at that. We had not specifically looked at what was the latency between the full immunization and the onset of a breakthrough case. I also want to caution you that, remember, the breakthrough cases are only for people that get tested and know that they have COVID. We know there are a significant number of people that may choose for multiple reasons not to test. When we look at the breakthrough cases, we have not been able to discern what we would call a typical phenotype. And I think we may have talked about this before, meaning there's not a certain age group, there's not a certain race or ethnicity, there's not a certain census tract where we're seeing these in Tucson. But I will follow up with that question in terms of the latency between when you were fully immunized and the onset of breakthrough cases. As far as the third shot rollout, it's a very pertinent, timely question. As you know, the immunocompromised patient right now can seek vaccination at all the sites that are given vaccines, including the Pima-County site, any of the pharmacies that are out there, the hospitals that are giving shots, and or any of the private places, as well as all of our mobile clinics. Our mobile clinics are designed and set up that you can get a shot if you identify as immunocompromised. The one thing to recall is we are not requiring a prescription or any proof that you are immunocompromised. This is an honest relationship between us and the person coming in that is saying they meet the criteria for immunocompromise. However, the larger question, I think, is what are we going to do when we have to immunize a significant number of people? Now, you will recall there's a time part of this, which means 8 months. At this point, the speculation is it's 8 months after you were fully immunized. That means that if you recall back, remember the 1A group, that means that the 1A people, those who are healthcare workers, assisted living, long-term care, those who minister to the deaf and dying, fall into that category. We believe that that group of people, we are hoping we can work closely with the hospitals as well as pharmacies to get those people immunized. However, we are also looking at the need for what we would call mobile or pop-up clinics, perhaps many in the footprint of where you saw the pods in the past. Remember, there were 4 pods in the Tucson area. And we will be working to develop an aggressive plan. We've already looked at the numbers. We believe on average, we will have to give approximately 20,000 vaccines a week for a multiple month period. So our goal is to ensure that we have enough ability, enough assurance that we can give that number of shots starting September 20th. Thanks.
Okay, Nicole, you are next, and then Mark follows that.
Hi, Dr. Cullen. Can you explain what the county's hospitals and ICUs are seeing in terms of pediatric COVID cases? How frequent are they, and how severe are those cases?
Yeah, so I really did just check the numbers on pediatric admissions. Now, once again, this is related to the identity in the hospital record that somebody is COVID positive. So right now we have high single-digit numbers in the hospital. This was in our hospitals, this was as of yesterday, that are considered pediatric patients. You'll remember for most hospitals, that's 18 and less. We have seen severe cases of COVID in our pediatric hospitalizations, meaning we have cases where people have ended up in the ICU. As of now, based on the data I have available, there have been no deaths in that population. We also have reports from the pediatricians in general that they are seeing more cases now. However, those are not ending up in the hospital requiring more acute care. Thanks.
Okay, Mark, you're next up, and Christina, you will follow after that.
All right, thank you. Hi, Dr. Cullen. Joe Gerald from the University of Arizona told us recently that he expects us to be seeing about 300 deaths in the state by the end of the month. What are your thoughts on that, and how could that affect us here, or will affect us here?
Yeah, well, you know, I have the utmost respect for Joe, and I read his analysis every week, and I don't take exception with most of it. We have seen an increased number of deaths, but not a significant increase. But you will recall the significant increase usually lags for many reasons. First off, people end up in the ICU for a protracted time, usually on oxygenation or some kind of support, and then they fail, and that's when death occurs. And then the death is recorded in the death certificate. That in and of itself is another 2 to 3 weeks lag time. So it's not uncommon for us to see this lag time of approximately 3 to 6 weeks after deaths. In terms of how it affects us here, I think the most important thing to remind everyone is the goal is to not get COVID, to stop the transmission of COVID. We, for a long time, felt that we had good data in terms of being able to predict, and you'll recall these things that put you at risk for death. Age, remember early on that was who died, certain underlying chronic diseases. However, at this point, as we see, presumably because of the Delta variant, a more aggressive number of cases occurring in the younger population, younger meaning less than 65, there's this increasing concern. And I think at this point, it is just a concern. There's not a way to validate it that we may see increasing death in that population. So I would defer to Joe. He does great analysis. My concern from a public health perspective is trying to stop the transmission of the virus. And then if you are infected, to make sure we have appropriate care available to you in your community. Thanks.
Okay, Christina, you're up, and Cheyenne will be next.
Hi, Dr. Cullen. So my question is about current school guidance. Previously, school guidance was kind of based off the fact that we didn't have a lot of people vaccinated. And so high transmission would have meant previously that schools would probably not be in person. So at what point would we get to the point where the health department would recommend schools returning to maybe hybrid or not in person?
You know, first off, Christina, that's a great question. I don't know the answer to it, but let me say what we're doing. We are doing everything we can to keep schools open. We believe students need to be in school. What you have seen, and all of you know this, is that we have shut classrooms. We have aggressively evaluated what happens in a classroom when there is an outbreak. If we can keep a classroom open, we do. So what that would look like is we have a littles class, like a second grade class. There's a table where there's been 3 infections, but there's no infections in the rest of the classroom. We're going to isolate that group. If they have any contacts, we're going to quarantine them, and we're going to keep that classroom open. However, we also close classrooms, and we close classrooms based on the number of outbreaks we're seeing, the number of cases we see in that classroom, and an evaluation of the environment. Are people moving around? Is there no way to ensure that people have a 3-foot window between them? So our goal is to really keep the classes and the schools open. Right now, especially if we can encourage and get compliance with masking, I would hope that we do not need to go back to hybrid. What we do know is some of the classrooms we have recommended get closed, or groups in that classroom go to either isolate or quarantine. We are aware that there are some classes that have gone to hybrid during the time period of isolation and/or quarantine. So our goal would be layered mitigation, compliance with masking, make sure people wash their hands, make sure there's adequate ventilation, do what the schools do well and what they've done well the last year and a half, which is understanding layered mitigation and integrating it into their classroom setting. Thanks.
Okay, we're a little past halfway through the press conference. If you want to ask a question, but raise the hand in the teams. And we have next up is Cheyenne and Benito after that.
I see your question, Cheyenne.
She's left a question in the chat. Now that most students have returned to classrooms, what does the CDC pima-county-health-department recommend as optimal staffing levels and positions in nurse offices to help ensure COVID safety? It's well known that there's been a statewide nursing shortage in schools for many years.
This is, Cheyenne, this is a great question. I don't have a specific answer in terms of ratio. What I know is that the nurses in the school districts are working as hard as they can. They're working very long hours. We are asking them as the public health department to do more and more. They are our eyes and ears at the school level. They are working with their principals and their teachers to help identify at our request who may be potential contacts. Now, the health department decides who is a contact and who needs to quarantine. At the same time, as you know, there's been encouragement for the schools to participate in pooled testing, which is being offered by the state, and or use the Binex Now or a similar antigen test at the school. Most of those tests are being done by the nursing and the nursing staff. We are doing everything we can to help support and encourage that there be adequate staffing. As you guys know, however, one of the reasons for the concerns about the hospital is the lack of nursing, respiratory therapists, hospitalists, staffing at the hospitals. That lack of staffing, because of the tremendous impact of the COVID pandemic, has affected the schools. And so not only is there this chronic understaffing of nursing, there's also many nurses that are electing to sit this one out, or for other reasons to take other positions away from the schools. So I don't know the answer to what is optimal nursing. What I will tell you is we are hearing repeatedly, almost on a daily basis, that whatever is out there is not optimal and is inadequate to provide the type of care that needs to be given at the school level, specifically for COVID. We are trying to offset their needs as much as we can by providing as much one-to-one, meaning public health department to school support as we can related to the COVID pandemic.
Okay, Benito is next, followed by Ariana.
Hi, Dr. Cullen. Thank you for taking my question. I'm wondering, with the University of Arizona semester coming up and announced 8,700 new students, as well as snowbirds who typically come down in the coming months, I'm wondering how this will shape the expectations for the Pima-County Health Department.
Thanks, Benito. It's a great question. I want to preface it by saying we are working very closely with the University of Arizona. As you know, we've been doing that the last 15 months. They have a public health advisory group. We have representation, which is me, on that group. So we help advise them. Obviously, we don't make the decisions for the U of A, but they rely on us to inform them with what is going on. Obviously, we're concerned. Right? We're going to have a huge influx of students coming in a very rapid time in a way that they were not here last semester. And that is what is the more immediate concern. We are worried about the snowbirds, but we hopefully anticipate that they're 4, 6, 8 weeks away. But right now, we are working with the university to help develop guidance for them, with them, on when testing should occur and when masking should occur. You're probably aware last year they tested routinely every week with some different guidelines. The hope is that at some near-term point, we will be able to ensure that there's adequate testing occurring both on campus as well as off campus, so in what we traditionally refer to as the high rises, to make sure that we can get early, what we call early sentinel awareness if we're going to have an outbreak. I do want to say, I want to remind people that the Delta variant and the R naught, you guys have heard this before and talked about R naught for a while because we were kind of stayed, but it's considered to be either 5 or 6. I tend to use 6. So every person that's infected can infect 6 people. So you can see what that concern is, right? As you bring in a large student population, who we hope by and large are immunized because they're eligible for it, but we know some of them won't be. You could see how you could have a rampant, rapid spread, comparable to what we had last year, if you'll recall, in September. So our hope is that people will mask, people will be vaccinated. If they're not vaccinated, they will test on a regular basis. We also know that the university is looking at, we are encouraging the university to look at cases in congregate living, a la the dorms, and if they reach a certain level, that the whole dorm gets tested. And that recommendation will be coming from the health department to the university.
Okay.
Thanks.
Ariana is next, and followed by Danielle.
Hi, Dr. Cullen. I wanted to ask a little bit about the 3rd dose of the COVID vaccine. I know you touched a little bit on it earlier, but can you explain a little who should be getting this vaccine? And then also, what's the possibility of having to get a booster shot from here on out?
Those are great questions. So who should get the current 3rd dose is if you fall in the category of immunocompromised. There's some easy ways to think about that. If you are currently getting chemotherapy, if you have had a transplant of any organ and you take medication regularly to make sure your transplant stays working, if you are on chronic prednisone, and that's defined as 20 or more milligrams a day, if you have a disease like arthritis, rheumatoid arthritis, and you go to an IV infusion center once a month and you get IV medications, those are most likely medications that are what we call remitting agents, and they're immunomodulator medications. All those people are eligible to get a 3rd dose now. And if they are eligible, we encourage people to go get that. There's no point in waiting. Now, remember, this is just for Pfizer and Moderna. There has not been a recommendation for those who got the Johnson & Johnson vaccine as their 1st dose. We do anticipate that we will see some recommendations on that in the next 4 to 6 weeks, but we don't have them right now. And then, as we move into September 20th, the 3rd dosing, once again, will be available to anyone who is 8, right now at least, and I would say this might be changed, but to anyone who is 8 or more months past their complete vaccination. So once again, September 20th is the date that the feds have thrown out there. That's the assumption. Remember, the first vaccines we got were around December 17th. So the thinking is that's 8 to 9 months after that time period. Thanks.
Ricky has a question clarification in the chat about the R0 number. When you say 6, is that for Pima County, the state, or just kind of Delta in general?
It's Delta in general, Ricky. It's actually a great question, and you're seeing some reports now of a Delta of 5. I guess my feeling is I don't want to minimize that there's not a difference between 5 or 6, but anything over 1 is worrisome. So the bottom line here is the transmissibility of Delta is significantly increased compared to the transmissibility of previous variants, and we need to be very cautious about what the impact that will have on the number of cases that we are seeing. I want to harken back to how I started. We had 401 cases today. I'm sure you guys monitor the daily cases as much as I do. That's a very, very significantly high number. Now, some of it may be because all of a sudden a lot of cases got reported today, lots of variability that can affect that number. But what's important is the ongoing increase in the number of cases we are seeing on a daily basis, explained by the Delta variant in the community.
Okay, Danielle will be next, and then Bud with the second question.
Hi, Dr. Cullen. Thank you for taking my question. I know that transmission within schools was relatively low last year. If you just looked at the number of outbreaks compared to cases that were coming into schools from children's homes. So my question is, are classrooms still safe, and why or why not?
It's a great question. I think classrooms can still be safe. And the reason why I say that is the school districts have worked tirelessly to ensure that there are adequate approaches to layered mitigation. Once again, wear, wash, wait. In addition, there is hopefully the compliance with the ability to vaccinate anyone who is 12 and over. So high vaccination rates increase safety in a classroom. The schools themselves have paid attention to the best practices that have been out there. The caveat in all this is masking. And as you know, we have recommended for the last, I think, month now that K through 12 mask in school. The reason for that is the need to stop transmission of a disease. So what we most worry about with the schools is this concept of outbreaks, that one kid goes to school, high transmission, not masked, other children or staff or faculty get infected, and then they go out. Remember, it's almost like a ring. You start in the middle and you can infect a lot of people that way. I think when the schools and the students can be compliant with the layered mitigation, the schools are as safe as we can make them right now. And we really need children K through 12 students to remain in school. So I feel comfortable saying schools can be made safe, but it is an agreement between parents, students, and the school district to make sure that every opportunity to mitigate transmission of this virus is seized. Thanks.
Thank you.
But I think we can squeeze in one last question. Let me just also point out that next week, we're planning to do another press conference with Dr. Cullen, time TBA on Tuesday, and then one with Dr. Garcia on Friday. So that will be our media availability for next week. But Bud, go ahead and get in the final question.
Okay, very quickly. You talked about 800 cases, school cases. Probably by the end of the day, it'll be 850 or so. Right. There are 75 to 90 cases a day. I'm sure you're very concerned about that, especially when you look at Marana and some of these schools that don't have a mask mandate. Where do you draw the line, and how much further will you let this go before you take some kind of action, and what kind of action might you be able to take?
Thanks, Beth. Those are great questions. I need to remind people that it's really the school district and the school boards that make decisions that impact what can be implemented and or utilized by a school district and by every school within that district. Our recommendation is people continue to use the layered mitigation and they mask. We don't have an ability to do anything beyond that from the public health department, but I don't want to minimize that. My hope is that by us being very clear that masking is a crucial, essential part of protecting those who are in the classroom, students, faculty, and staff, that schools and parents will comply with the recommendation to do that. If I could enforce that, I would. And so what I urge the boards and the parents and the students themselves, get vaccinated and make sure you wear a mask when you're in school. Thanks.
All right, thanks everyone. Sorry, Craig and Benito, we didn't get to your second questions. If you want to email us, maybe we can get you a written answer or two. But then we'll see most of you next Tuesday. So, and if many of you already have, but if you want a copy of the recording, just please leave your email in the chat and we'll get that out to you.
Thanks, everybody. Thanks for all you're doing. We're really grateful at the health department for your helping us message and ask us questions. It's helpful.
And thank you for doing this.
Thanks.
We really appreciate it.
Okay, bye.